heart rate is not able to compensate. All right? Yes?
How quickly would glucagon reverse the beta blocker?
Not quickly enough for us.
So then my question is going to be, like when we look at the low blood pressures, we're thinking about, is it a rate problem or a volume problem or a contractility problem? So you can't do anything about the rate. Would you give that person fluids to try to bring the pressure up? Or
Absolutely.
Okay.
Wait,
Right?
can you?
So you fix. So you're gonna get fluid. So you're gonna prime the pump, right? You're gonna do everything you can to prime the pump. So you fix the fluid issue first, make sure that's not the problem. So you get your fluid, then what? Rate, then what?
Contractility.
Okay, so you're pumped then, right? So is this person having problems with their myocardium and their pump?
No.
No. So we have our fluid problem and we have the potential for rate problem, right? So if we give a little bit of fluid, right, we prime the pump, so everything's good there. The only thing we have left to do is to fix the rate, right?
So if their rate was really low, would atropine do anything? Because they're on a beta blocker?
That's a great question, Andrew. I'm glad
Could
you asked
you
that.
pace them?
Okay, so hey, there's your blood sugar, 55.
You can pace them.
55's not horrible. It's not great.
Horrible, but is it something that we fix?
Yes.
All right. All right, so here we go. Here's how some of these are going to react. Track it, read it.
What's toxidrome?
Where's what?
Opioid toxidrome?
Just a combination, just combining medications. You have the opiates plus all the other medications on top of it.
Would we want to start by taking the opiate out of the
Yes.
mix?
Fix the stuff that you can fix first, and fix quickly. Because who knows what happens if you give this person Narcan, boom, they awake.
Took out the opiate.
So what is a normal person that awake? Does their body initially start to mentate better, and does it start to try and recover and fix some of the irregularities in those blood pressure and stuff? They'll make an attempt, right?
Will the opiate also dump our blood pressure and heart rate as well?
No.
No.
Unless it's like a heroin style that they've been down and they've been hypoxic and they ramped up and now they're already
And now we're
ramping
seeing
down.
it on the
They're ramping back
downside.
down.
If you take care of the easiest one first by giving you Narcan, it also gives a little more information on what they could have taken more of.
Exactly. Like you want that mentation to come back because that'll help a lot, right? Like all of a sudden she's awake and talking to you, you're like, oh, so what did you take? I didn't take a thing. Let's try that again. I just brought you back to life. I can let you go back. I mean, you wouldn't say that, but
I'd be banging.
yeah. Right? So you get the mentation up, you may get more of the story, right? Be like, oh, actually, I only took the atenolol. And I chickened out with the other one. It's like, oh, cool. Those are good. Like, we got things that we can fix, right? But if she says that, she goes, yeah, I only took the oxy and the atenolol, and that's all I took. What do you think, based on the presentation right now?
I think you took metformin too.
Why do you ever track that?
Yeah, because the
Is that a normal low blood sugar for somebody that doesn't have?
not a kid.
Okay, what about a 17-year-old female?
Not anorexic.
What else? The supple neck.
Oh, someone. Go, right? Every time.
no.
You're what?
Confused with the supple neck thing.
Ignore
Yeah.
the supple neck. You're thinking way too much about it. Okay?
I can't.
I know you can. I know. I put that one special for you in there. Okay? I just want to keep you focused. I knew you'd be dozing off right about now. I put something like that in there. I actually had some things later on in this thing where I actually started putting some of you guys' names into some of these things, just for the fun of it.
It's like,
But then I decided I was going to delete those names, and you know, it may come back when we finish this one on Thursday. But yeah, so you call her bluff, right? Because low blood sugar is like, hey, you know what? You're not telling the whole truth here, and I have facts that are going to tell me otherwise. Okay? Your blood sugar is low, which shows us that you took this drug. Okay, well maybe I did, right? Because when you catch somebody in a lie, most of the time what do they do then? When you give them facts, they're just like,
Nope.
okay, well no. Usually they'll come back with like, okay, but you gotta be a good lawyer in like you build the case against them so that they can't deny it, right? versus saying like, I know you did it. No, I didn't. I know you did it. No, I didn't. Like, you just can't go back and forth with somebody like that, especially in this type of situation. But if you say, no, I know you did it because this medication that you potentially took is designed to drop your blood sugar. Your blood sugar is now this low, and therefore, it proves to us that you took this medication. Huh, got nothing there. You're right, I did, right? And so it's that kind of thing. Okay? All right, so.
Oh, wait, we go back so we can
Yeah,
finish the
we
rest
never,
of
we
them?
Sorry.
never talked about
Sorry, oh, we
the,
just talked about
Gab.
the opiate stuff, right? So we give her opiate. She wakes up a little bit.
We've already
Dictation
talked-
is better.
We've already talked about that atenolol with our BP and heart rate.
Yep.
But gabapentin,
So
what's additive?
wait. So if the glucagon didn't work, you would then give atropine, and then could you potentially pace and use pressors?
Come on, Noah. Come
What?
on up. Come on up.
You didn't.
Come on up.
Ah!
Take a muffin.
No.
All your food.
So Noah, we're on. So you want to talk about atenolol?
Yes.
Okay. Let's. If you guys have any questions about atenolol, Noah's here to reason through it. Okay. Let's go from there. All right, atenolol. What do you guys want to do for atenolol?
Give glucagon.
Don't take it easy. You gotta face the class. Okay? Anybody else have any other questions about atenolol?
You said that's not going to work very fast.
Okay, good.
So what would atropine do?
Potentially speed up the heart.
But would the rate at 54 and the blood pressure at 70 be horrible? What if we just dump some fluid and try and help with fluid before we try and pace?
Total glucagon actually.
So maybe this patient might not be theoretically the best person, but say if their blood pressure was 50 over 30 or something.
Would we still try and push fluid too to try and dilute the medication they have and put some more fluid in the tank?
I mean, yeah, but that's going to take a while.
What's going to,
Why would you even give glucagon then?
I mean,
The
'cause that's
theory is
gonna-
like if you're waiting for it to work, but you don't want to wait, why give glucagon?
I mean, because you
It
could
still
do other
needs-
interventions while the glucagon takes effect. So you could give glucagon
And give fluid.
and give fluid. Those are both going to be more slow-acting things. They're not going to immediately just. Versus, I don't know if you could pace this patient, but that would be an immediate. I feel like that
I
would be.
don't know if you can pace this person. Can you pace any patient in the world?
yes.
Oh,
You can do whatever
Okay,
you
so-
want.
Just go ahead. Okay.
You can
So-
do whatever you
Then
want.
I would probably rule out atropine because that's also going to take a second to work, and I would go to pacing because that's going to have an immediate bump up in the blood or in the heart rate, which I think would then bump up.
Would you
the
guys
blood
expect this
pressure.
person to be bradycardic with a maybe third-degree block or second-degree block? Or would you expect this person to be sinus bradycardia based on the EKG on the previous
I
slide?
bet atropine would work.
Oh, geez, here we go. Hey, now you gotta go ahead and have a seat. Thanks. Thank you, Noah. Way to be a good sport. So you've got sinus brady, right? So would we expect atropine to work on a sinus bradycardia?
Yes.
Absolutely, right? So absolutely, atropine could work. With that being said, is this a real bradycardic kind of a patient?
No.
It's being controlled with the medication.
Right, so it's being slowed. Is 50 for a normal 17-year-old? Is that
Not
a
horrible.
high, low, medium, could be
Well,
expected?
I'm thinking the supple neck might be a little overweight, so she's not like fit and 50.
17-year-old track star, could be.
Oh,
Could be a 17-year-old with a supple neck.
but does the track star have a supple neck?
Right? So taking a look at your patient, this is where like creating your ability to reason through this stuff, okay? Is 50 really bad? Yes or no?
No.
Is the pressure bad, really bad? Yes or no?
It's borderline.
Right, so this is where we go back to our fluids, give some fluids, see what happens, and ultimately the rate is lower than it should be, yeah? So maybe just by giving the glucagon, giving the fluids, get that process started, maybe that will bump it up enough that it's like, hey, we've given our Narcan, we've got our mentation going, we've got some things heading in the right direction, we're gonna hang out and monitor this for a second and see if anything changes. If nothing changes, and this pressure still is bottomed out, we're starting to get too much fluid in there because we're doing an awesome job of monitoring our what?
Vitals.
Lung sounds, right? So now we're starting to get a little wet sounds going on. So now we're like, okay, this person's still hypotensive. Now we start to transition over into the atropine, potentially pacing, your pressors, that route, okay? CNS suppressant stuff. CNS suppressant stuff. How do we manage that? Airway, breathing, circulation. Airway, breathing, circulation, right? There's not a whole lot we can do. We don't have any antidotes for it, so we don't have a lot there. So that takes care of both of those. And then we got our D50 for that, okay? All right. Let's see. All right, focus your attention, right? Down here at the bottom, vitals and pupils, right? Pupils, quick to the eyes, okay? You gotta get quick to the eyes on people. It's one of the first things as you're checking your mentation. Hey, are you okay? She may moan at you. Grab those eyelids, pull those things open and take a look, right? Yeah?
Yes.
When you hear somebody say, hey, I got pupils of 1 to 2 millimeters, is that small, big, medium?
Small.
What if I said that they're 6 millimeters?
Big.
What if I said 3?
Normal.
2?
Small.
How can you tell the difference between 2 and 3?
Get out your pen light.
So let's say pen light
Hold
look
them.
different from what the light is.
They look abnormally small,
Yeah.
right? Anytime they look abnormally small, is a time where you start to be like, this is something that it draws my attention to it, right? If it draws your attention that they're abnormally small, it's probably that they are affected by the opiates, okay? Let's see. Overall physical examination, what kind of stuff are we looking for there on this patient in our physical exam? Skin?
Any other things they did to hurt themselves?
Any other traumatic events and the age, so if they have scars on their wrists, if they have anything along those lines, history of any sort of overdoses in the past, anything like that.
Track mark.
Needle marks, yeah, anything like that, okay? Skin is gonna be a big picture painter for you.
If it's supple.
Supple neck,
Only
right?
in the neck.
All right, so you got your opiate overdoses, meiosis. What's meiosis? Biology.
This is something
How
with
about, let's go
cell.
medical terminology. Pupils? Pupils. So your pupil sizes, okay?
Meiosis is pupil size?
Pupil size,
Condition
okay?
of the eyes. Condition of the mind. Condition of the eyes.
Condition of the eyes, okay? Small versus big, so these are gonna be what? In the opiates.
Small.
Hyperventilation, are they gonna be purple when you get there? A lot of times they are. A lot of times the people are very cyanotic because opiates eliminate your respiratory drive
By the time you get there,
by the time we get there, right? Okay, most of the time we'll get called for cardiac arrest because they're not breathing, right? CPR is being done on them. They still have a pulse, but they're just not breathing, right? We get there, check the pupils, because we walked up and that's what we do. Drop our OPA, patient accepts the OPA. Be like, oh, hey, let's get some Narcan, somebody get an IV, we're gonna start bagging this person. Okay, in goes the Narcan, not 4 milligrams like what the cops give, but we give our 0.4 milligrams, because what do we wanna do? Just wake them up enough to start breathing, right?
This
Because-
patient we want to wake up to meditate though.
I don't know, do we?
You just
to
said
get a
that.
history.
Yeah, because they're not
The 17-year-old.
breathing at this level. You want to
Right.
meditate for history.
So this is the perfect patient to wake up all the way. If you have somebody on the street that potentially took heroin, I'm doing just enough to wake them up, just to wake them up, just enough to get them breathing. Okay? That's why it drives me bonkers that the cops have all these milligrams of Narcan, right? So they slam somebody with 4 milligrams of Narcan, and it's just like, we get there and they're like, hey, yep, got an OD for you. I'm like, yeah, awesome. Who wants to ride in the ambulance with us now? Because this person is a handful, right? Whereas what can we do if we're just getting them just to breathe?
Get them just to the hospital.
Titrate.
Give them 0.5 till right before you get to the hospital, and then you give them nothing.
Every once in a while. Yeah, I know I told you guys that story.
What?
Right?
0.5, and then when you get
I told you
once
guys
you
about the
roll
story that I
in.
did right before I left Western Lane?
Yeah.
Yeah?
Yeah.
I'm pretty sure I did.
Yeah, that's why I referenced it.
Yeah.
I've heard of other
Told me the
medics
story.
doing that.
Huh?
I've heard of other medics like and we're at the hospital, there's the
I don't
rest.
do it to the hospital, I just do it to people I work with.
Yeah.
Much funner that way. Because then, like, with the hospital, you rarely get to hear about it again because, like, I don't interact with people at the hospital. But, like, when you do it with your own crew members, you'd be like, you son of a, like, for years to come. It'll stay with them, okay? Coma, you got your Brady because they're on their way down because they've already tacked it
Ramped
out,
up,
and
and
then
then-
now they're ramping back down. And then hypotension.
Because they already hypertension and now hypo.
Yes. Yep, they ramp up and then they ramp it back down. Let's see here. So, okay, got basically the opposite effects. Everything ramps up. This is the beginning phases of it. So you're gonna end up with super high tachycardias, hypertension.
Our anticholinergic, what's our anticholinergic?
Anticholinergics. What would be an anticholinergic type of effect? Okay,
Is that what,
is that?
that's not an
Try
anti,
it, try it, try it.
isn't atropine an anticholinergic? Yeah.
That's why I
Okay,
thought.
let me, so we have our cholinergic, which is gonna present with our
Sludge.
organophosphate.
Oh,
Okay, so there's our organophosphates,
Damn.
right? Close, you just flip-flopped them, okay? So you have your sludge type effects, right?
Right,
Salivation, lacrimation, urination, defecation, GI, and emesis. Yeah?
yeah.
You guys totally got all those, right?
Yes.
But bam.
Although
What
the
page is-
silor
That's saliva.
saliva.
Yeah, salivation, yeah. This is
Oh,
when
yeah.
my computer died, I changed it to salivation, and my
Oh.
computer died and didn't resave it. Salivation, lots of saliva.
Yeah.
Okay, so the cool thing is they both start with
I
S,
just like
okay?
What's the BB band?
Then you get the BB band, bradycardia, bronchiuria, bronchospasm, abdominal pain, and the meiosis. Okay, what's gonna happen with the meiosis here? What's gonna happen with these?
Eyes will be
Why?
They're gonna be big,
Deer in the
right?
headlights.
Right? Abdominal pain. What kind of abdominal pain?
getting ready to
Throughout.
poop it all out.
Severe cramping, okay? Because what happens when you have severe abdominal cramping? What does that lead to a lot of the time? Blowout.
Explosive area.
Oh, dang it. Right?
Is that because of all
Like,
the?
this is like the perfect storm here, okay? So organophosphates, so these are your pesticide styles, okay? Pesticide, where would we find these types of things?
Farms.
Crop dusters.
Farmers, crop dusters, right?
The country.
Yeah, that's what I said, pesticides. Where are we gonna find this?
Well,
No, we-
This is
He's going down
Yeah.
That's why we use the cramp.
Yeah.
Because it's just a huge-
Everything, basically, you're dumping all, yeah.
Because the
So if you go out like the rural areas, go to those rural areas, these are gonna be long transport times. Okay, so you're gonna have long transport times. So how do we deal with sludge-like symptoms?
Atropine.
Atropine.
Two Pam.
Japan.
Two Pams. Let's see here. I got another. Skipping these just for a second. I want to get to something.
Carnaloxone chloride.
Yeah.
And
uh,
a lot
Comes
of
in the vial and you're like,
and a lot of atropine.
Whoa.
I like
I
it.
hope so I say that one.
Where did it go? That was right there on the next one. You guys reading all that? Getting it all?
Yeah.
Oh, yeah, totally.
We've seen a couple of these before.
Alright, let me search
Go to the
it.
rain project.
What was the anticholinergic?
what's that?
It's gonna be our atropine overdose?
Has a kid from Georgia.
Oh, no.
What? Have you not seen?
Oh, antihistamines.
It looks so good. I think
So there's another acronym that can be used as well.
Dumbbells?
Oh, so the way it works is it like breaks up the yearly cells. And then we get food, I drink like, I just basically like get it out, I guess.
Diazepam. What's diazepam?
That's a wet patient sledge dumbbell.
Are gonna like.
What's diazepam? Diazepam Valium?
Alright, so.
Valium, yeah.
It was,
Or the diazepam for the seizures.
Yikes! That lady's guts were
I mean,
terrifying.
I guess it's
Did
what
they
you're
see
getting
that?
older.
Yeah.
I was getting it. Light enough.
Alright, so yeah, so our treatment for this is exactly that. So we go with atropine. How much atropine are we going to give for this?
As much
1
as we
milligram
have.
every 2 to 3 minutes until secretion's dry.
Do we have that much atropine?
No.
Not in the world.
Huh. Not in the world.
Well, okay, maybe
That's
in the
quite a
world.
statement. Okay, so we're gonna need a ton of atropine, right? So is this a multi-unit assist
Yes.
kind of thing?
And the chief officer.
Oh, what do you got there? What do you got there?
A picture.
Oh, we got a picture of 2PM. What is 2PM, Dustin?
It is atropine and
And
per-
good.
Parallelodoxin.
You're able to throw out 2PM.
chloride.
Are we going one auto injector or two auto injectors?
Two.
3 for severe.
2 injectors or severe 3.
Okay.
I have a question about that.
Oh, stand by.
For those, for
No,
EpiPens.
Stand by. So, how do we differentiate between moderate and severe?
Respiratory failure and going.
Oh, man. Bad is bad. Medium is like they're still alive, right?
Yeah.
Yeah? That's a
Yeah.
good approach.
Severe seizures, skeletal muscle paralysis, respiratory failure, and coma.
Oh, so basically they're dead or near to it. Yeah?
Yeah.
Yep.
Yes.
When it says 2 auto injectors, are you getting 2 separate pens, or is it like an EpiPen where you have?
No,
you do
two
one
separate.
and then
They're
you
two
do-
separate pens, so it's an entire, they come just like an EpiPen, where it's, you can take the whole injector and you just do 2 of them, and so they come in little packs of 2 already. Probably got a picture of it.
Okay, why don't they just package it and go on?
Because maybe pediatric needs it, who knows?
Or the mixing them together might not be
Then
beneficial.
you got dirty needles coming in, going out, coming in, you just, yeah. All kinds of
How do
different
you,
reasons.
how do you regulate it for a pediatric thing? Because what's the
You
milligrams
don't.
on that?
You don't,
You can't.
you don't.
So you just,
You just give
the point of having a dosage for pediatric is like.
Right. Does it say in the protocol one
No,
injection?
it says 25 milligrams. Is that
Yeah, it says IV
25 to 50
infusion.
milligrams. Slow IV push, no more than 0.1 milliliter per
So how many come?
Reconstitute 1
12
gram
milligram in
powder
one
vial
kit.
with
Or,
20 ml of Sarah water
600
per
So you got
in
injection.
one
12
kit.
you got 600 milligrams in one, and you got 25 milligrams per kilo in a kid. So, I don't know, I've never actually tried to draw out of that. I don't know if it has the ability to be able to draw milligrams out in those. I would have to look at the actual kit, the auto injector. I don't know if you have a port to be able to draw that stuff out.
You have to have a 24 kilo kit, so that's a heavy kit.
Is that, do we have a bunch of reserve for that?
25.
In case of bio warfare, or what?
The city does have a large.
Where's the silos with it?
It's totally totally top secret for everybody. Well, for all of you.
50 per case. and
Just like
everything.
there is a large cache of atropine as well.
Where is that?
Not where you have access to.
Do you have the codes?
I do not have the codes.
It's over in
but I know where
building
they are
4.
located. Okay?
Do you think
Yes.
the amount of stuff that Eugene Springfield has on standby?
I feel
Yeah.
like you should too.
What?
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 I don't know, something's happening here. I don't know what.
I'm just trying to eat my crumbs.
At what point are we having to work this person? Are you guys doing all this?
Oh no, you're doing it all on the way. Yeah. Nope, so basically OPA, airway management, give the Narcan as they come around. That's when you're making the transport decision, because the glucagon takes a little while to take effect, so maybe eventually you'll get that pressure up by the time you get to the hospital. So yeah, you're loading basically, you're doing your quick fix there, and then making the move.
How long is a little while? Like 30 minutes, an hour?
No, like 5 minutes.
Oh, okay.
Yeah. So like I like Narcan and D50 that are instantaneous, and adenosine, which is instantaneous.
Yeah.
I like those kinds of meds versus something that takes 5 minutes.
Instant gratification.
Yes.
Yeah, I didn't know when we
I
were
like,
talking
I
about.
like instant
So
happiness.
for the like for dextrose and the Narcan, would be something you do on scene to see if it works.
Yes.
If it works, then we'll stay.
Yes.
If not, then we're good.
That's why I was confused about like I knew glucagon took a while, but I didn't know like how long of a while we were talking about.
Yeah.
So
Okay, so let's see, 1:30. Okay, so we'll finish this one on Thursday, but I got one quick question for you. Don't everybody blurt it out all at the same time.
Yes.
So the question of the day is in regards to adenosine. This is a trivia question. Okay?
It's not gonna have us.
I'm just excited, so don't blurt it out, but when you think you know the answer, then raise your hand, okay? Dustin?
Nope. Nope.
Yep, you just did it.
Okay, so adenosine has a half-life of approximately how long?
5 seconds.
Let's all blurt it out.
Well, now it's all lost.
It's not very often that like I just want to walk up and just kick a table over. Right now it's one of those moments.
So you push it with
I have.
Why are you laughing? You're not so fast.
That's incorrect.
I gotta say that's probably the fastest I've ever heard. you
That's
just-
about the half-life of adenosine.
Right. Does anybody have a secondary thought on the half-life of adenosine? That's not
I raised my hand and I was gonna say 6.
I thought you
Right now, I don't even know what's happening with you guys. So I don't even know if I can get to the actual real question.
Oh, that wasn't the question.
Okay, so let's not say anything. Like I tell my kids, we're gonna play the silent game. So let's all talk right now because I don't want to play. Blah, 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 blah. It's like that game's over, right? No fun. Okay, so adenosine has a half-life of blank. Okay. So, at what point does that half-life begin when you push the medication?
I've been wondering that myself.
Okay. When you think you know the answer, raise your hand.
As soon as it goes in the.
God bless it. You guys.
Mons, you're so good.
I caught myself. I'm gonna shut up.
No, really.
Okay, raise your hand when you know when the half-life begins. Chandler, without looking it up. If you're over there typing it, I'm going to put you in timeout too.
Okay, you want me to give you an answer? Is that
No,
right?
I just want to know if you have an idea of when the half-life begins. Does anybody have no clue?
I have an educated
Oh.
student.
Oh, B? You have no clue? Okay. Oh, Noah's doing this. So, with a raise of hands, I want to know who thinks the half-life begins as soon as it enters your IV site?
Wait, IV site. Be more specific.
I mean, it's honors the vein.
So
Is that
you
your
have
tubing?
You have your tubing, right? Here's your tubing. This is your patient. You have your double port here, right? We're using double port, so we got our medication here, and what do we have up here?
Another
How
port.
much fluid?
Flush.
How much?
10 minutes.
20.
A little louder, B. How much?
How much what?
How much fluid's up here? You just said it.
60.
60. We want at least 60 up here, okay? So we use our big syringe up here, okay? So 60 here, we got our flush here, okay?
Yeah, the dose here.
All right, so we're gonna go. So
That's
hey,
our-
so here's our.
You said flush.
This is our amount of medication right here, okay? So it is right here, okay? So we're not gonna go fast. We're gonna go slow motion. I want you to tell me when the half-life begins, okay? So boom, in it goes. Nothing, huh? Oh, we got it, you got it. Oh, yeah, oh. We got some hands.
I'm gonna just. Proud.
Pickles.
Supple neck.
He's been dreaming about this for a long time.
Is that his heart now?
It's in his heart.
Oh,
Oh, we got it. James, you didn't even raise your hand at
I
all.
thought it was the moment it interacts with any other thing, so the moment you squirt it.
Right here. Yeah?
And your hand should have been up still.
Yeah. Why is your hand not up then, James? You didn't even participate. Unbelievable.
It's the moment that it hits
Blood.
blood or tissue.
Yeah, that was blood. Because it's a natural.
Why?
What's the
'Cause it-
answer?
I know the answer and I'm going to tell you. Oh, go ahead.
No, I don't know
Noah, you
why.
got
Go,
it.
Noah.
Tell 'em.
Dude, I don't know. It's a natural enzyme in the body, so the body naturally breaks it down. So as soon as it gets into the body starts breaking it down.
It's an enzyme,
Or I don't know, it's an
enzymes in the
Enzymes
body?
that break it
All
down.
right, are you ready?
Give us the actual answer.
Are you ready?
Yep.
So,
Nuclear. That's
the half-life starts when it hits the blood itself. It is metabolized by the vascular endothelial cells and erythrocytes by cellular uptake and is rapidly metabolized there. It's metabolized in a bunch of steps which ultimately ends with uric acid. But that's why the half-life is about 10 seconds, unlike most meds that are metabolized by the liver or
I
kidneys.
thought it was 10.
So there you go. As soon as it hits the blood, the half-life begins.
As opposed to other drugs, it'd be the
So the
liver.
reason this came up is our new IV tubing have a carb eject and a normal port, right? You can't push the fluid fast enough through the normal needle port to be able to flush it. And so then we were trying to figure out, okay, could you use the same port here and put the fluid into into your drip set of because it's only 2 cc's,
I might cut it off.
and then basically hook your new syringe up to the same port and then flush it through there. Could you do that?
Why
Yes.
well,
not?
if it only holds 2 c's. Well, how many? I don't know the
It holds,
concentration. of
you can
the-
fit 2 cc's. Yeah, it's 6 milligrams and 2 cc's.
Oh, okay.
But if you try and go with the 12 milligrams, now you got 4 cc's. You can't fit 4 milligrams between here and here. Huh.
You go fast.
Right, but it doesn't
Could
matter.
you put it in your
because
flush
you don't have
then?
enough time to take it, switch it out, and then push the next
Could
one.
you put it in your flush then?
So here's the way to do it. So you just take a 3-way stopcock. It solves all the problems. You just hook both syringes up to this 3-way stopcock. You push, you flip the switch, push it again.
Did you know that it also works for people with baldness, probably?
Good to know.
Adenosine does?
With
what?
minoxidil.
Wow.
I can honestly say I did not
We
know
just
that.
went a whole.
All right.
They'll have
Yep.
baldness.
All right, there you go. See you guys in an
I
hour.
learned something new.